afternoon. Welcome back from your tea. I'm so glad to see so many of you still around. This is our last segment of the conference, the fourth symposium. And I'll cut the superfluous comments and go straight to the point. We have three very experienced speakers who will share with us the expertise in ways in which the elder care service in Singapore can be enhanced. So the first speaker is none other than Mr. Lynn Boone. He's a very well-known figure in Singapore, and he was the appointed chairman of the Ministerial Committee to Aging, and currently he's the chairman of the Temasek Holdings, an NTUC enterprise cooperative, and he's also the deputy chairman of the Singapore Labour Foundation. So please join me to welcome Mr. Lynn.
Good afternoon, ladies and gentlemen. I was invited by Lawrence some months back to participate in the conference. He caught me at some gathering, and then, of course, in front of everybody else, I had to say yes. So I'm here. And he asked me to talk about the subject of new directions in the future elder care landscape. We think of how to care for a frail, aged person in care centers, in nursing homes. Now, this approach may result in a poor quality of life of our seniors. You ask yourself, after you have visited a nursing home, whether it is a place you would want to go to when you are old and frail. Those I've asked on such occasions reply, no. So when we discuss the future elder care landscape, what is the right question to ask? They will lead us to the right solutions. And it seems so obvious. Do what seniors want. What is it that seniors want? They want to live. Life is for living, not to be cared for. Can we live when we are in a nursing home? Well, nursing homes do a good job keeping us breathing and our hearts beating. But are we alive? What does it mean to live? To be alive? I am alive when I have a reason to wake up for. When I may do things to feel the rush of adrenaline, something that gets me excited, something that gives me satisfaction. So what is there to look forward to? What purpose is there for me to live one more day? So if I'm frail, I will do rehab. All those exercises they tell me to do, if there is a reason to live. Otherwise, it becomes an imposition on me, keeping me breathing, but making me go through another meaningless day. Each meaningless day is a torture to my soul. Is that what seniors are telling us when they say, I'm old, I'm useless, let me go? On and off, I've looked at elder care issues, but never studied any issue to any great depth. I'm not like Professor Kwa Yok, who has done a lot of studies. I'm not like that, not that kind of intensity. What I have learned is mostly from observation. And there's no better lesson learned than real-life experiences with people close to me. My mother has been an active person her whole life. She lives with my unmarried brother in a single-story semi-D. Until last year, when she was 90, she was doing all the housework, cooking, cleaning, tending to the garden. But she was getting frail, more bent, and her knees hurt. Then, out of nowhere, she was struck by the CMRSA superbug on her left hand. Now, fortunately, after early intervention, the surgery was successful. However, she was weakened and could no longer keep on doing what she had been doing, especially post-surgery. We got her a domestic worker or helper, which opened up a whole set of new issues. The language barrier added to the difficulties. It's not easy when you have been doing things your whole life by yourself, now to have someone look after you and do things for you. I think the mental and psychological barrier to cross is much more difficult than we imagine. So it has been a difficult adjustment. One day, the helper was in tears, so I had to explain to her to let my mother do what she wants to do herself. But the helper should watch to see that my mother does not get hurt. So, of course, my mother says the helper is lazy. On the other hand, she says the helper is spending so much time gardening. I'm not sure she understood the contradiction between what she said. When I'm free, I take my mother to church for the Saturday evening service. So during the day, my mother would then set about preparing dinner. My wife tells me we should not let her go to so much trouble. I tell my wife it's something for my mother to do. She has a purpose for that day. So when we grow old, what do we want to do? Too often we leave the question unanswered until we are actually old, retired. I have a friend who is really a model for aging well. He prepared early and actually retired young. He has several circles of friends. A couple of these circles are golfers. A couple of others are schoolmates. He went to different schools, so different circles of classmates. And these circles have regular get-togethers. So he meets friends very often. And he's the one organizing these get-togethers and finding the cheapest places to hold these get-togethers. And in recent years, he has another activity that keeps him busy, playing with his grandchildren. I wish more seniors were like this friend of mine, who is prepared well and enjoying his senior years. When I walk about a lot of hawker centers, and recently I have done a few more, even though I'm retired from politics. I often meet groups of people eating and chatting. These are friends or family members. They meet weekly. Some even bring food they cook at home to go with a coffee or tea at a hawker center. Actually, it's not very good business for the hawkers. A cup of coffee lasts 2 hours. There are groups that gather to do qigong or tai chi in our parks. And of course, there are also mahjong kakis who get together on weekends and public holidays. The People's Association is constantly encouraging residents to form interest groups so that they will age well and care for one another. You not care for one another, but look after one another. Look out for one another. And people naturally form groups when there are opportunities for them to do so. What a PA is doing is to speed things up, to get as many of our people into interest groups as possible. And at the same time, the PA encourages our seniors to take care of their health. But just forming groups and socializing is already taking care of social health and mental health. Now, such groups give seniors something to wake up for, opportunities to socialize and provide each other with mutual support, caring for each other when one needs help. And sociologists call this building social capital. The deeper the social capital, the more resilient society becomes. And the mutual support friends and family provide has a good financial outcome as well. The cost of elder care comes down. If you have chance to talk to Ministry of Finance people, whether it be civil servants or the politicians, please tell them that, because this area requires a bit more funding. The KPIs are not so easy to derive, but it's very important, and they should understand. Now, as we age, the body gives way. We become frail, forgetful. We can be a danger to ourselves if we stay home. One option is for us to go to a daycare center. And I learned some lessons when NTUC started to operate day centers. First, seniors are happy to go to our centers if it is to live. And one reluctant and skeptical man was persuaded by his daughter to give our day center a try. He was very reluctant to go. Daughter said, give it a try. He decided it was a good thing because it has a club-like feel. He actually told the daughter, I don't mind going to this club. He didn't say, I don't mind going to this daycare center. Now, seniors want to live, and therefore want freedom of choice on what they do at the center. A rigid program of activities deny them control over their life. There is a strong case for allowing seniors to organize their own activities. Now, people forget their aches and pains when they are absorbed in enjoying what they do, like playing mahjong. You don't have the activity, you have no end to the grumbles which they're about my ache here, my pain there. But when they are busy playing mahjong, all those are gone. So let's design day centers as club-like activity centers drop the term care, and we will do a better job. Let's position them as wellness hubs, encompassing physical, social, and psychological wellness. Let's make it a place seniors look forward to go to meet friends, learn new things, have new experiences, enjoy activities like mahjong or karaoke, exercise to strengthen and aid mobility, engage the mind, contribute purposefully, interact with the young. So don't tuck away our centers some corner somewhere. Put them right in the heart of where all the activities are going on. Some seniors will need to go to nursing homes when care is needed. For most seniors, entry to a nursing home is a one-way ticket. They stay there until they are carried out. And too few make it home after rehab. We need a culture of choice and self-control for seniors so that seniors get rehabilitated quickly to be well enough to go home, assisted by home help. When in a nursing home, seniors should be enabled to live. Today, our architects are told to pack beds into nursing homes. We provide too little social space. Now, where can family or friends chat with the senior other than by his or her bedside? So why is a nursing home designed like a hospital when our seniors are supposed to live there for an extended period of time? So are we designing hospitals or are we designing homes? We say nursing homes. When NTC Health was awarded a nursing home to operate in Jurong West, one of the things I set about was to try to tweak the design so that there is more social space. Say a garden setting where family or friends can have a cup of tea together with the senior. And we are working on making the nursing home a part of the community, owned by the community, not an institution which residents would not want in their backyard. Instead, we want residents to interact with nursing home residents regularly, use the facilities for themselves too, such as the gym. We got a gym, so no reason why residents in the surrounding areas cannot use the gym. For the time that the person is staying in a nursing home, it is home to that resident. Like a home, they should have choice and control over food, activities, social interaction, moments of quiet, sleep, what they wish to wear, or how they wish to do up their hair. Like home, they should be able to do things with family and friends. And our seniors should be able to go into the neighborhood because it is where they live for the time being. Now, NTC Health has expanded from day centers to home help services and nursing homes. The goal is to help seniors get well enough so they can go home with home help. That is where they really want to be, home, the familiarity of home, in the company of loved ones. And we need to train home care officers, which we call eye care officers, to understand our seniors, to be able to interpret what they say, to know what they are really saying, and know what they really want. Right? You interact with your own senior relatives, and you know that what they say is not necessarily what they want. So seniors of the future will be better educated and knowledgeable, used to independence, and want to live life. Home should be the first choice for seniors to be in, followed by day centers, and as a last resort, in institutions like aged homes or nursing homes. Wherever they are, we should strive to give seniors a sense of purpose, empower and support them to live as independently and as much as possible, with ample opportunities to interact with other people, including family and friends. So this is how I see the future landscape of elder, not care, elder living. Thank you.
Thank you, Mr. Lin. Our next speaker is Dr. Christopher Lien, and he is the Senior Consultant, Geriatric Department in Changi General Hospital. And he has several stints in overseas stints in Scotland, Australia, and USA. And he has special interest in community, transitional, intermediate, and long-term care. Please join me to welcome Dr. Lien onto the stage.
Thank you very much, Yao Ling, and thanks, Prof, for inviting me here. I am a geriatrician and also awkwardly conscious that for those of us who come from hospitals, we have a very microscopic view of the world. You know, we see the world through the lens of our hospital beds. And sometimes, I don't know whether you feel that, you know, but sometimes we offer solutions to relatives which are very difficult to implement the minute they leave the clinic room or they go home. Our conversations are dotted with adjectives such as you must do this, you should, and why didn't you? You know, as if it was, life is so easy. And I guess that's the insight I had after I listened to Mr. Lim. I mean, how do we offer choice? How do we help people stay connected? How do we help people stay active? But more importantly, how do we help people live? And how do we also maybe allow people to take some risk? Because in general, the minute you are old and you have had a fall, suddenly the whole world is afraid to leave you on your own. And I don't know, I mean, I think I would struggle with being watched 24 hours a day, you know, and what more, a helper that follows me to the toilet, follows me when I try to get out of bed, watches me when I put on my underwear, you know, I don't know. I don't know whether that's what we really should be aiming for. So in the next 15 minutes or so, let me take you through a deck of slides. You know, we us hospital doctors also hide behind the PowerPoint. You know, we're not like Mr. Lim. We don't have enough wisdom, so we use slides to pretend that we know a lot of things, right? So I thought I'd just cover three things. You know, community rehabilitation. What does it mean? What do we have? And what do people want? And I tried to study some economics, so I went to a public policy school, and I guess, you know, the word need doesn't factor into an economist's vocabulary usually. It's all about supply and demand. But let me take you through a few ideas and we come back and see. I think my talk and Street Fund's probably fairly complimentary, but I thought I'd take the liberty to just remind ourselves what's rehabilitation. I mean, rehabilitation, even though there is a specialty called rehabilitation medicine, is very much embedded in the practice of geriatric medicine. When patients come to hospital, it's usually because they are unstable. So as doctors, we tend to just stabilize disease. But after we stabilize disease, usually patients are fit for discharge, right? So we discharge patients. Or if they refuse to leave the hospital, then we decant them to another facility that is willing to take them. But after that, there's often a period of optimization. And the optimization is where perhaps a little bit of rehabilitation begins to become increasingly necessary. And we rehabilitate disease, we optimize disease, we also try to improve function. And the concepts really, these are universal concepts. Just because you've got multiple impairments doesn't mean that you should be limited. And just because you have multiple limitations does not mean that you need to be handicapped. So that's the whole concept, right? You want to try to help people improve and be in their optimal condition. This kind of slide, this is an old MOH slide for about 10 years ago, right? So the concept is, where rehabilitation is not one person's job, and it's therefore multidisciplinary. There are lots of people that give rehabilitation. And so the physiotherapist, the speech therapist, social worker, psychologists, and other therapists. But then, does it mean that every time I have a little bit of a problem, I need to see 1, 2, 3, 4, 5, 6, 7, 8 people just to get better? So every time I go into a hospital and there's a little bit of functional decline, 8 people come and say, where do you live? Who do you live with? Are you safe by yourself? How many hours a day do you? And so this leads me to ask, to put a red question mark: is rehabilitation necessarily multidisciplinary? Surely all the components are important, but does every single person need 10 people just to get better? Is good care necessarily more care? I suppose that there are many ways to look at rehabilitation. You can look at the body, you can look at the psychology, you can also look at the environment. But whatever it is, I guess people don't argue that in order to figure out what is rehabilitation, you need to actually assess, plan, give us a treatment, evaluate. The nurses will recognize this, right? The APIE framework, right? And then after that, you need to sort of take all that into consideration and provide some care and give some advice. So at the heart of this is actually assessment. And if you've been to any AIC meeting, they will say, we must have a national assessment framework, care assessment framework that has to be systematic and comprehensive, right? So that comes the other question. Before we do any rehabilitation, we must have a comprehensive assessment. And if you look at all the geriatric literature, the textbooks, and the way we teach our medical students, comprehensive assessment, is part and parcel of what we're supposed to do. And so what exactly is the comprehensive, how comprehensive must you be? Head to toe, eyes to ears, to toenails, to skin, so what exactly, and is it really necessary? There's enough evidence to say that it's necessary. But you see, the problem is it's not about the assessment. Right? A lot of us say, no, you must have an assessment. Before we can start, we must have an assessment. Before the physio sees you, we must have a comprehensive checklist. Before the OT sees you, we must have another comprehensive checklist. Before we can hand you over to the community team, we need to have a comprehensive handover. Before the OT or community team can accept you, they must repeat the comprehensive assessment. No, that's not what it's really about. Because if you look at all the papers, it's not about the blooming assessment. It's really about the long-term management, the multidisciplinary interventions after the contact, the continual interventions at home and the multifactorial interventions at multiple different levels. That's what it's about. It's not about the assessment, even though the assessment is important. If this is the framework, then where do we provide it? We provide in the hospital, sure. There are lots of ambulatory care facilities, and there is a slight problem there. We want people to get better. We want them to come and participate in a program that is sufficiently intensive, sufficiently progressive, and sufficiently consistent. But in the hospital, most of our follow-up appointments are 2 weeks, which is neither very intensive, nor very progressive, nor very consistent. Right? But that's where it starts. Ourselves in Changi and previously in Alexandra Hospital, there was a very ancient concept known as the geriatric day hospital. And that's where we try to bring everybody together in the spirit of day care, day rehabilitation, progressive interventions, and multidisciplinary working to try to develop a care plan. And behind the concept of the day hospital, is the PACE program. Those of you who've studied the PACE program in America will know that in North America, they have shown that if they assemble a whole bunch of interventions in a systematic way and give patients progressive systematic interventions, they improve and stay out of hospital. And the health management organization saves money. In Singapore, we have an equivalent. We have the SPICE centers, which is really the concept of the day hospital minus the regular doctor, minus the case management, minus the whole bunch of other things, So there's SPICE, we call it SPICE, it's PACE minus. And it's not bad, but it's not always able to provide the rehabilitation that we wish and we want. So rehabilitation is also provided at home and in long-term care facilities. So what is it? What is it? It's a combination of problem identification, goal setting, care planning, referral management, and really closing the loop for all of that. And in general, we have general programs. So basically, when you need rehabilitation, we can refer you generally to the center. And of course, when you refer to a center, you may or may not get what the center can deliver, or the center may not be able to deliver what you need, right? But there are also specific programs, So if you look at hip, stroke, Parkinson's disease, so the hip program, we've started in Changi to work with St. Andrews to come up with a systematic way of delivering hip fracture surgery and post-discharge rehabilitation. There are some stroke programs in Singapore. The PD Society, Parkinson's Society, has got a community rehabilitation program in Bishan. There is increasing amount of pulmonary rehabilitation, and there is increasingly heart failure rehabilitation in the Heart Center, and so on. So the theme is that it's intensive, progressive, consistent, and it's also quite outcomes focused. But if you look at stroke as an example, this is a very common outcome that we get, right? This is contractures in people with a stroke. The thing that really surprised me when I worked in Scotland was that I hardly saw contractures. In fact, I'd forgotten how common it was until I came back and I suddenly started seeing contractures in my clinic. I said, hey, why is it I didn't really see it there? And there are a whole bunch of reasons why. Yeah? So outcomes, how do we avoid these outcomes? And I must show you this picture. This is Auntie Kit. Some of you in the room know her. She's a retired GP. She's 86 years old in this picture. And she had a hip replacement when she was 76. And she continues to go ice skating, right, on a daily basis. So this versus this. How do we get more of this? Of course, there's a lot of other factors. There's genetics, there's predisposition, and so on and so forth. But how do we maintain this kind of vigor and vitality? So I'm going to take you through a few pictures, right? Rehabilitation. If you look at the literature, there's a lot. This is the SMJ list. You just Google rehabilitation, you get a whole list of papers. Google the Annals of the Academy of Medicine, and you get a whole bunch of other papers. So there is a lot of work on rehabilitation and its benefits in Singapore. Then you look at the AIC website. I just want to take you through a few pictures on the AIC website. People are smiling. It's quite good. Yeah? But there are lots of people sitting. Right? So if you look at this, it's... So where are the people who are standing? Okay, they're not in the day centers. Okay, so that's perhaps right. But then where is the emphasis for people getting back on their feet? Is aging about putting, must go to day center, sit down, and so like sit on walls, all in a row, you see? Everybody doing exactly the same thing. Raise your hands when you raise your hands, put your hands down when you put your hands down. So is this the message of aging, right? So let's look on. I'm not trying to be insulting. I'm not really criticizing AIC. It does a fantastic job. Okay? But this is just really about the way we present services in Singapore. Again, we most of our activity focuses on sitting. And perhaps we need to change that, right? This is in nursing homes and the positions that we see. There is it's better than nothing. There are lots of things you can do. There are lots of ways to be healthy. But where is the mobility? I wanted to show you this. Not because there's anything wrong here, right? So I wanted you to see these two ladies. Look at this lady. She's sitting in a nursing home, and this is a national picture, mind you. Yeah? She's sitting in a bed, cross-legged, which means she's got good cross-legging ability, which means you can sit with unsupported sitting balance, right? Which means she's really pretty good. And look what's happening. There's a cot side for her safety. Now, if I did that in a nursing home, if I was in a nursing home and you did that to me, I would be so frustrated. Misi, right? Yeah, so that's the way we message our therapy. Now this is the guidelines to center-based care, right? This has just come out, and it's really, if you've not looked at it, it's great. It's an implementation guide to a whole bunch of things that we're introducing in our day centers. It's got lots of good things inside. And I wanted to just show you this. This is the therapist in Meta looking at the guide, This is from the AIC website, so presumably he's looking at it with awe or admiration, But behind him is a whole bunch of equipment, right? And this is something that we are, perhaps the beginning is near. This is the HUR equipment from Finland. It's designed to calibrate strength, and each person goes onto it with a card. Just wanted to show you, hang on. And perhaps there is some opportunity to begin to work on strength and balance exercise. I'll show you some more of this in a short while. Okay? Just wanted to show you this about the home. If you're at home, you can get 18 visits for active rehabilitation over a 4-month period under our current framework. But if you are labeled poor rehab potential, then you only get 2. So there's huge discrepancy. So between the good labeled rehab and the ones that you don't recognize, there's not a lot that you can do. And one could argue that everyone needs some rehabilitation, some active rehabilitation. Now this is some work we did with AIC in our hospital. We looked at all our referrals to the day centers. 70% of patients never made it there. Right, so we refer, 70% of the patients don't go. We have since put in a bunch of improvements to reduce the risk of this. But we also know from Gerald's work that even though that stroke rehabilitation is important, up to only 30% take up post-discharge rehabilitation. So rehabilitation is not looked at favorably. Is it because it's no good, or is it because it's inconvenient? Is it because it's too expensive, or is it because it doesn't give us what we need? And this shows you our readmissions for strokes. If somebody comes in the hospital, that's 30%. The 30-day readmission for patients with stroke is very, very high. If you have any diagnosis of stroke, this is your readmission rate in our hospital. So it shows you, look at how many of them are 25 to 30%. That means a quarter of them come back after 30 days. So I wanted to take this just say to everybody that not all patients are the same. Not all, in fact, there's a difference between those who are terminally ill, very severely frail, or moderately frail. But each person has the need to be able to improve from where they were at, and our exercises are not just general exercises. Go to a nursing home and use your hands and go round and round the pedal bike, or sit down in a chair and go round and round on the pedal cycle. I mean, that's not rehabilitation. And you look at the bulk of our day centers, that's what we provide. So where is this? This way of looking at goals, that everything has an opportunity to improve. This is adapted from a study we did with Duke. We showed that if we put in a systematic program that is intensive, consistent, and progressive, patients improve, right? And this is what I wanted to show you. This is an initiative that we did with the Lien Foundation, and it's really uses the tonic example, and it brings the HUR equipment into the daycare centers. How many of you are part of daycare centers that have some experience with this equipment? There's some of you here, right? So I mean, it's beginning to really recognize the difference that it could make with progressive intensive therapy using equipment that's self-calibrated, that works on strength and balance as well. So maybe we do have to rethink this and think about options of delivering some of this care. Okay. So to wrap up, right? So the IHI has this roadmap to suggest how rehabilitation be carried out: systematic, transitional. But in Singapore, we have a system of services that cater to patients with different levels of frailty and provide different intensity of treatment. And from higher levels of intensity to lower levels of intensity, and differences in capability, but patients don't always land up in the right place. So I guess the biggest question is, how do we then provide this kind of thing where the care manager evaluates what the patients need, the social worker perhaps does some social support and gives some supportive therapy for the losses that people face. The financial counselor does a whole bunch of things to look at willingness to pay and ability to pay and preferences. And at the same time, you're always tracking whether people go or the 70% of people who don't go. But having said that, if you have so many coordinators, whose job is it to coordinate all the coordinators? It's probably the fundamental question, right? So, what does community rehabilitation mean? Who is it for? The need is to recover and beyond the acute episode. What is available? There's a lot of fragmentation. There's a huge gap in skills. So there's a lot of asymmetry between what one center knows, what another center knows, and a whole bunch of things. And is there a demand for rehabilitation? From what is currently available, I'm not sure. I'm not sure there's a huge demand. Is there a need? I don't know. Maybe we can pick this up at the discussions. This is the new aging master plan. There's lots of interesting things inside. But perhaps this is what we want to see a little bit more, even for the very frail. Okay, so I'll end there. Pass the floor on to Swee Fan.
Thank you, Chris. Before I introduce the last speaker, just to make a request, during the panel discussion, please feel free to write your questions on a piece of paper. We will come round and collect the questions from you, okay? If you're feeling too shy to raise questions. Okay, last but not least, I'd like to introduce you to Dr. Wong Swet Fan, and she is a senior consultant from the geriatric medicine department in Khoo Teck Puat Hospital. She holds several key positions in the Alexandra Health Care System and also Yishun Community Hospital in the perspective of healthcare innovation and research. So please join me to welcome Dr. Wong.
Can you see me? Okay, good afternoon. I really want to say first thing, congratulations, Gerontological Society of Singapore. Oh, thank you. Now you can see me. Okay. Congratulations. I really want to say that the talent, the commitment, and the progress we have made exhibited today really tell me that we can be confident of an aged but good Singapore. We are getting there. Thank you. Thank you for all of you for your wonderful presentations today. And I also want to say something. I really finally heard something inspirational today. Mr. Lim, thank you. I think your speech was the most inspirational today. And I hope that after my presentation, I can say to you, the future is here. Okay. And to Chris, no, we don't overlap. It's okay. Say all that you needed to say. Okay, I'm supposed to talk about healthcare for the older adults in the north. Why in the north? After all, Singapore is just a small little dot, right? What north is there to talk about, right? So we're not talking about Malaysia here. We're talking about the north of Singapore, okay? And people will ask me then, where's the north, right? Anything in the red, brown, and green is supposed to be the north, okay? Why did I put the blue there? That's because Northwest CDC also covers there. And so because we work with them, we count them in as north also. But we realize that sometimes we step on NHG ground. So north is basically a region that Ministry of Health says the regional health cluster, you are the regional health system of the north. So that's there are 6 regional health systems. We are in charge of the north. We're called Alexandra Health System. We serve a resident population of 800,000. We started off with one institution called Khoo Teck Hospital. I think more people are familiar with that name. We started in 2010. We added to that fold in just last year, Yishun Community Hospital, and we're going to build some more. All right, so it's going to be a lot of work. 2020 will probably be finally ready. But we always remember there are 6 regional health systems, but only one healthcare system. And so whatever it is we have done and learned from the north, we really are sharing with the other systems. Plus, they are sharing with us to try and see if we can get the best practices to be implemented in the whole of Singapore, so that if I have a parent who lives in the north, but another parent who lives in the east, they both get it. Yeah? So let me move on very quickly to what we do. The healthcare to me is very simple. I know I'm a geriatrician, I'm not supposed to talk about all these things, but you're not going to see a typical geriatrician here. Okay, 3 very simple things to do. If you're not yet sick, we do not want you to come to hospital. Okay, we try to keep you out of the hospital, and we try to prolong the time when you will first meet us at the hospital. So you're in the green dot. According to the traffic light system, that's the place to be. Now, sometimes you do need to come to us. Okay, if you meet an accident, you come to us. If you do, our job is to treat you well, swiftly, and get you out as fast as possible, yeah? Okay, that's the red dot. That's where you do not want to be, okay? But when we send you out, we must also support you in the community, all right? So, very simple, 3 in the traffic light colors. We look at it slightly differently again in the Alexandra Health System. If we just draw a line right across, above is what we call community, below is what we call institution care. Okay, but if you look at it, there's another line, right? Over there, you will see today's problems, because people who are old are ready with us. We have to help them. We have to support them, right? But if we only focus on that, tomorrow we'll have bigger problems, because we're aging faster than we can come up with solutions. So we have to work on the green side as well. So as a regional health system, you have to take care of everything, not just the old people. Yeah? Okay, I'm going to start with the institution side because we started as an institution, one institution, Kutekpok Hospital, and part of it is historical and part of it is the traditional way we address problems. Like when we don't know how to care for an older person, what do we do? When we don't know how to care for somebody, what do we do? First, we professionalize it, correct? We get the experts in, ask them, what do you do, what do you do? Then we send people to learn and we do this very well, okay? Then after that, we get a few specialists, then we centralize them. Why? Because we have to improve our processes, we have to increase our productivity. We only have so few of them to care for so many people, so we centralize and we bring all the people to them, all right? Then third, what do? We institutionalize them because now we just build a wall around it, we put the rules around it. Now you can do this, but you cannot do this. You're not qualified, you're not accredited to do this, so you leave this to us. So what happens is that the world is now in order, correct? Yeah, but we forget. We forget about the people behind these walls. There's a lot of convenience. We go back to our own lives, and we forget that this is not life, this is just care, as how Mr. Lim said. Okay? Not only if we forget, it becomes expensive to look after people this way. Okay? And thirdly, we stigmatize it because with this now, people don't want to live with these institutions nearby. We create NIMBY syndromes. So we have to move beyond, okay? Professionalizing, centralizing, institutionalizing, we have to move out. And so we need to rethink the future. Caritas is what we do in the north for dementia care, very similar to what NUHS has done and what the DPP is about, except that I think they have a lot more evidence-based and studies. But what we do is, while we have expertise in the care that has started from the hospital, okay, we actually try to make it more normal to receive care in the hospital. If you are in the garden and the doctor comes around to do the walk round, we don't call you back from the garden, sleep in your bed so that the doctor can see you. The doctor goes to you in the garden. And if you're in the garden and the therapist is here to do therapy, okay, they go out into the garden to meet you. And so we also include horticultural therapy, art therapy, music therapy. I have seen the amazing work done by the music therapists. There was a Saturday when I did a walk around, this old man was so disruptive, and all the music therapist did was she came up to him and she went, and very soon he went, and very soon, she started him singing. And by the time I finished my walk round, he was playing the piano and singing with her. That not an action required by the nurse, no extra tablets, nothing, no restraints. And so you see, there are no restraints in our wards. They are just distracted, they are introduced to new activities. We have recently celebrated our 1,000th restraint-free day in our ward. And to the architects in the audience, we recreate the environment so that it helps to guide them into the right activities. So for example, if you look at our doors, we call them Harry Potter doors. They are painted like bookshelves so that those with dementia and who want to wander, they will not, right? From this is just inpatient care. We need to move this out. And so now we move this out into the community, all right? Just go to the website, forgetusnot.sg. Really, you will see the compelling stories why we need to build dementia-friendly communities. If every Singaporean could extend a hand a helping hand to a vulnerable neighbor. We will not need gated communities. So to Prof. Fong's earlier question, this is something we need to build capability in. I had a personal experience in this. A young man came to see me. Dr. Wong, what to do? My father every day buys 6-pack beer for me, you know. And why does the father do that? He has dementia now. He used to buy beer and share with his son, but he didn't drink anymore. He remembered buying beer was very liang, you know. So he buys it for his son. And that was their way of bonding when they were young. And he continued to do it in dementia. So we sat down, we said, okay, let's see. We didn't stop him from buying because that was his way of bonding with his son. So we went down to the shopkeeper that the father bought from, and we told him, hey, look, every morning I return the 6-pack. You give me back the money. I give him the same amount of money. So the same $10 went with the same 6-pack went round and round and round and round, you know. So every day the father continued to do what he wanted to do. The son continued to receive, but no money, no real sale was done. But there was a side effect to this, okay. One day, the shopkeeper called up the son, hey, you know what, your father didn't come today, something is wrong. The side effect was we created a social support network for the father unwittingly. And with that, actually, a lot of other countries have started dementia-friendly communities. We likewise need to. We started this in Chong Pang. We have trained people from the police force, from schools, from the retailers, okay, to try and identify, recognize features of dementia and not stigmatize them, but support them. Really go into the website. You will really cry when you see the stories, okay? And this was done with Lien Foundation. Thank you, Chris, for your foundation's help in this. And the happy thing is more communities are wanting to be dementia-friendly. So Dr. Amy Koh, Hong Kong, and now she wants to introduce DPP. Wonderful, right? We don't have to worry, Lawrence. Okay? Yeah, so, you know, just from that, we have created what we call age and dementia-friendly communities, but we still need to support people in terms of more expert kind of care, because there is a difference. Medical needs at home, you will need to support them. And so we do that when we discharge patients to the community. We have what we call the Aging in Place community care teams to try and reduce people from returning back again and again. We had this problem because we sent people home, we thought, hey, we did a good job, huh? Then how come you come back? Not once, but many times. And really the truth was we didn't do a good job, yeah? And so when we support them in the community with our Aging in Place teams, which are really nurse-led case management teams, to help them in everything. They just need to do everything and not necessarily medical. We have seen 3,000 patients already. There are 10% who pass away. Most people who are admitted recurrently are really near the end of their lives. Okay, so 10% have passed away. At any one time, we have 700 people actively needing our help to go out there. So we have 10 teams, 24 nurses currently just going out. They don't work alone. They work with healthcare assistants as well as our community partners. And those, some of them, they have to go to nursing homes. So we don't stop there. We go into nursing homes to support the nurses to help the patients in the nursing homes. So let's meet Mr. S. This is one of our Aging in Place patients. He's 83 years old when we first met him 2 years ago. He had diabetes, and he was very active still. And one day while he was cleaning his house, he crashed a vase. It broke, the glass that shattered, cut into his leg. He thought he could handle it. A week later, it was gangrenous, septicemic. He got admitted to SGH. It got amputated. And so that was a total change in his life. But he still made it, you know why? His wife was able to push him in a wheelchair, and he was able to continue with a social life that was still quite fulfilling. They even went to Hajj together. And then his wife died. And that was the day he became a prisoner in his own home. And because of that, he was depressed, he couldn't go out, he didn't want to take his medicines, he wasn't compliant with anything. He got readmitted frequently to Kutikpa Hospital, and that was how we met him, okay? But really, he didn't want to be like that, okay? And if you look at him, this was what he was doing in spite of his amputated leg, in spite of his wife's death, right? He was still cleaning his house. He's not one of those typical people who want to be sick and help me, help me, help me. He was helping himself, do his own laundry, do his own housework, all right? So this is what community rehab is about, okay? Our therapist went in, our therapist had to go to his home and try and wheel themselves up the slope where he lived, and found it was so difficult themselves. They were young, strong therapists, they couldn't do it. How could they expect him to, right? First thing that made him prisoner in the house, there was a big gap in the floor levels. East program came in, did that ramp for him. We took his look at his wheelchair, he needed an upgrade, and then we thought, actually can try scooter, all right? Did that. They went to modify some of that because he had some visual impairment from his diabetes. They had to highlight some of the controls, okay? Taught him how to transfer to scooter, get out of the house, into the lift, onto the pavement, cross the road, round the corner to his senior activity center, okay? This was where his life started. This was his social activity. But he continued to do shopping, marketing, okay, anywhere he wanted to go. And that was the slope that the therapist couldn't go up, right? And look, he's actually even doing what we call town audits. He can tell us, this place, the road not even. Can town council do something about it? Because that's not senior friendly, right? Yeah. So really, he's now an active member of the community in spite of his disability. This is rehabilitation, getting them to doing what they can do. And this is what we call the last mile. There's a short last mile. We have really great services. We have a lot of demand. That last mile, the chasm is very deep. We need to overcome that. We need to bridge that. Yeah. And the program did not stop there with just the nurses going into the homes. The students have come in. So now we're talking about intergenerational. And this one, we didn't ask the students to come in. They came in to ask us, can we help you? Right? They came in through Northwest CDC and said, these were students from NUS, School of Medicine, Nursing, Pharmacy, and Social Work. They banded together, about 80 of them, formed themselves into 20 groups and became student leaders. They went to the schools, secondary schools, and said, you all want to do CIP? We want to visit patients. You join us, we lead you. So together, you have NUS students with secondary students, school students, and the nurses visiting the patients in their homes. They started this tri-generational home care, okay? This is their first year. They did 22 committee members, 95 team leaders, 180 secondary school students, 80 patients. This year is their second year. It's finishing soon. They are going to graduate soon. So we hope that this will receive continuous support to go on and on and on and on and on. And their next step is they want to go to the poly. Can we get the therapists in as well? I think this is a wonderful initiative. These students not just learn to visit patients in the homes, they have self-organized, so much so they even have their own CEO, COO, Material Management Department, HR Department, Public Relations. They have done it all. They are actually ready for work. And we didn't even do much. We just there to mentor them. It is, you know, Singaporeans, very resourceful and creative, you know. Yeah, we have hope. Yeah, so this is the third part. tomorrow's problems that we need to address today. This is my favorite part. I'm still a geriatrician, I still do the other side, but this is the exciting part. Very hard to get results immediately. You would need about 5 to 10 years before any positive results come out, but I think this is the way to go. So while we do not need any acute hospital services yet, we still need to help level them up, all right? So a lot of programs are being initiated within these objectives. And I'm just going to go through some of them with you. Yeah? One of them is what we call our share a pot. Okay. We've heard very much so previously that the seniors, community dwelling seniors, are not getting enough protein in their food, in their diets, right? We hear it, oh, you know what is the natural response of doctors? Hey, go and eat better lah, go and get better food. And these seniors just, how? What? Start where? You know? Yeah. So instead of just dispensing advice, right, we decided, let's just go to it, yeah? So Share a Pot basically started a very simple idea. We want to give a meal of high protein, high calcium through soup, okay? And we know that within 2 hours of exercise, if you take a high protein meal, that protein goes into making muscle, okay? So you can make muscle, but making strong muscle is a different matter, okay? Making strong muscle, there's only one way. You got to exercise, okay? So we partner a good protein meal with exercise, okay? At the time when we started, right, no manpower lah, so we cannot do home delivery, so sorry, you have to come out of your home to get it, right? So center-based. Side effect is, I brought them out of social isolation, okay? Then when you come eat in a group, exercise in a group, you're not going to do it, sit down there by yourself, alone, don't talk to people, right? You start to talk to people. So social engagement starts. And after a while, same side effect came out. Hey, Mr. Tan didn't come down 2 weeks. I think we better go and visit him. Social support networks were beginning to form, and therefore little kampongs were starting to form. In addition, what we learned from HDB was that seniors do not venture further than 300 meters from their homes. So we know we should not be doing big centers, but we should be doing small little centers, very much like what Prof. Chong was trying to talk about, creative cities. Yeah. So we started Share a Pot. First one was at Our Lady Star of the Sea. See the lady there that's bending forward? That's Rosalind. She's the main honcho there. She's the one in charge. And they are actually measuring each other. So we actually teach them how to measure physical fitness, hand grip, weight, height, BMI. We actually get them to measure their exercise activity. We give them questionnaires, and every now and then we also organize talks for them. See the second picture, the old man with the white hair there? He's 87 years old. He's one of the ones who, after learning from the exercise coach, started to lead the others in exercise. Okay? The man at the market stall, he's our local hero. He heard what the young ladies were doing, going down to his stall to buy vegetables for the soup, right? He said, what you're doing? Then she said, oh, we are cooking soup for the old people. Oh, like that? Take lah. Then every time he has extra, you just take lah, never mind. So he started to give what he could. He couldn't give money, but he could give what he had of himself. So we saw so many things just by starting that. So one church, now one school, okay? This is intergenerational. The children are the ones that are measuring the old people. And down there, if you look at that last picture, the white-haired woman in the orange shirt, she's the RC member that decided to support the students. Okay? 2 nursing homes. So now the nursing homes are trying to be assets of their community. They have opened their doors to the community by starting share pots. They already have kitchens. They already serve food to the residents. Why not open to the residents? So they have started very successful programs. All Saints Home has also started community gardening. They've opened their gates to the community to come in to plant fruits and vegetables, which go to the share pot. Okay? And you can see the residents as well as the nursing home residents exercising together, right? And then now we have 3 wellness centers within Yishun, and these are real volunteers. They come, we don't even call them, they come, they start cooking. They now have started kopi and roti sessions, which is morning breakfast, sit around, and that's when the guys want to talk, you know, over the news. So it's been a really enriching experience for us all. I hear we are starting another one at Floral Springs next week. Yes, Alice is nodding here. And one more, Kranji Secondary School. So this year, one of our dreams is that we hope we will hit 10 centers. Yeah? We are 7 now. One of them. So this was also talked about earlier, co-location. We missed the boat for co-location of seniors with young, but what we did was that senior care centers co-locate with wellness centers. So now well elderly with seniors who need some amount of care could be together, and so those who were capable could actually go over and help the rest. And so since we missed the boat for children, right, we are now talking to the schools. Would you like to have your children come down and, you know, meet the seniors? So we're actually thinking of starting tuition centers here as well, and ask if some of the senior teachers could come and take tuition for and those objectives in the red, purple, and blue boxes were actually objectives worked with the seniors. We didn't come up with these objectives ourselves. They wanted these. So with that, then we plonk in the activities to support them. You know? Yes, this is what we always were taught, right? Traditionally, when you're young, right, you must learn first. After you finish learning, then you must earn money. Then after you finish earning money, there's one more stage that's missing here. The people say you yearn, you yearn for greatness, you yearn for fortune, you yearn for fame, right? Power. And then at the end of it, right, you return. Right? Some people don't have the yearn stage, so that's good. Right? They go back to it. So now what we do is we want to turn this way, yeah? Okay. So now we have lifelong learning, okay, lifelong earning, and lifelong returning, right? So, which means to say actually for those of us who have young kids, actually they can earn money also, you know. So I also teach my daughter, while you're young, please go and work. So while she was in university, she did part-time work. And I never needed to give her pocket money. So that's the good part for the young. But then for the older people, they want to learn. And a lot of them did not have that opportunity when they were young. And I'm sure there were a lot of you, or among you, your parents wanted you all to be doctors, right? Correct or not? Correct, right? That's why we started mini medical school at Kutipot Hospital. Okay? This is real medical school. We don't dumb down. This is not patient education seminar. It is not. These are not patients. Okay? They come in, they're actually students. Okay? We use the actual medical words and we explain the definitions to them. Yeah? It's our 4th run. We're now at 2016, now showing. Last Saturday we started the first session. This Saturday and next Saturday, it's mini public health school. Okay, we've also started children's camp. This is for primary 5 children. We want to raise healthcare workers of the future. You know? So we bring them in. They come into our radiology suites. Say, oh, X-ray machine like that. Oh, MRI like that. Oh, and they get very excited when they can talk to the radiologist, the surgeon, then they can talk to the nurse, the therapist, and we've had children, I want to be a therapist when I grow up as a result of this. Yeah. One message right down there that says, don't miss these very informative and useful sessions. They can change your life. I'll tell you a story of Mr. Nathan. He was 59 years old when he came for mini medical school. His father died at age 59. As a result of mini medical school, he went for a checkup. He took the advice. He went for a checkup with a cardiologist and found he had 3 vessels that were blocked. Yeah. And so he got himself admitted and had 3 vessels stented the day before he was due to come back as a valedictorian for that session. So he asked his cardiologist, sorry, tomorrow I got to go to school, can or not? The cardiologist, go, you're okay already. So he came back to tell the story. Because of going to mini medical school, he got his vessels stented. And he said, if I live to age 50, I will come back next year for your mini medical school and give you a donation. And at age 60, he came back and gave us a donation. It was satisfactory. And now he's volunteering for us. Yeah. So, at the North, really, we don't believe that we are the only determinants of people's health. If you look at it, healthcare only contributes 10% to your health, all right? 30% I can't do anything about. You have to go back to your parents for that, right? But look at that, 60% I can change. But truth is, we don't just have a healthcare problem. We have a health education problem, so we need teachers. We have safe housing, good roads, health, good environment problems. We need engineers, contractors, right? We have social, behavioral problem. We need coaches, mentors. We need everybody on board. You are all our partners in health. That is what we need, okay? And this lesson I learned very much from Ng Bee Ling, Executive Director from the South Central Community Family Service Center in Delta Road. She taught me this ABCD, asset-based community development. If I want to go into the community, I need to change the way I think and the way I work. And she takes the pose. First thing is, people are experts of their own lives. I may be an expert in medicine, but people are experts of their own lives. Okay? I need to give them back that control. Assets exist in the community, including seniors. Seniors are assets. We need to stop thinking about them as if they are problems, issues, and challenges. Okay? They are assets. They actually can create their own solutions. And who am I to say that mine is better? Okay? Relationships build a community, not advice, and we need to lead by stepping back, and we need to focus on strength, not deficits. And she gave this as a final picture, all right? When we talk about assessing the community needs, all right? Assessing gaps in the community, why we are looking at the empty side of the cup, right? But when we look at them as strengths and assets, we are now focusing on the full. And I think that is what we need to look at. To Prof. Fong's question again, I just think that what we need is empathy, tolerance, and creativity to change our mindset. Thank you.
Wow, such a good rounding up for the day. I'm sure that you have really gained a lot from the 3 inspiring speakers. May I invite Mr. Lim and Chris to come up here? Just to add on to that, it really gives me the sense that there is hope in the future. I'm old now, I don't mind getting older, or rather don't mind getting younger. Okay, we have a few minutes for you to ask questions. Please put up your hand and raise your questions. So, we have someone with a bowl coming around to collect the questions from you as well. Anyone?
No questions.
If you don't, may I just start the first question? This question is Mr. Lim. Because you're talking earlier on about like working and so on. So in your view, should we or should we not have a retirement age at all?
The short answer is no. And I share with you that I was one of those who objected to the legislation on retirement age. Because some time ago we didn't have a retirement age law. And then government wanted to, because people were working to 55 and then they were retiring. And that was because of the CPF. You withdraw CPF at 55. So that became our retirement age, accepted as retirement age. So government said we want people to work longer because they can work longer. So why don't make them or get them to work longer? So I said, okay, I was then Secretary General of the NTUC. I said, we will go and talk to the employers, persuade them to allow their workers to work until 60. We were actually very successful to get the employers that had unions to do so. But the problem was that we don't represent all the workers in all companies. So those companies that didn't have unions stuck at 55. So after government looked at it, then somebody says, then we pass legislation. Pass legislation. I was said you will have consequences which you will not imagine at the present moment. I said one of those I do not agree with it. But anyway, my colleagues didn't believe me, so they passed the law, right? So now they regret. Quietly, I can tell you that they wish they didn't pass a retirement age law.
There you are. You can work until you drop. Okay, there's a question. There's a question, why don't we have a retirement village instead of calling it a nursing home? Anyone can answer this question. I'll come to you. Why don't we have a...
Yes, why don't we? I think that's a wonderful thought. Okay, first of all, if there's no retirement age, no retirement village. Correct or not? Yeah, I think even to call it a retirement village is a negative frame. Why don't we have living housing that is lifetime? I think that's probably what we want to ask. And I think we don't have new models at the moment. We are only studying the models in other countries. And if we only look at models in other countries, then we may not progress to what may be even better for our own people. So this is an area we should think about. That's my quick view.
I guess I echo that. You know, the whole concept of a nursing home is a very, it's almost Victorian. You know, you think a lot of poor people don't know what to do with them, so put them in a place where they can all be together, so you can institutionalize them, right? So and then that model has not changed very much. The whole concept of dormitory beds, that came out of the Industrial Revolution days. If you look at models from the West, that's where it becomes a problem. Because if you look at American models, it's all about expensive nursing homes with private ensuite carpet you can get your meals provided you get concierge service so it's a very exclusive model. You and yourself in your own room with your old friends, with your old people doing old people's things in a very luxurious environment. If you look at Scandinavian models, it's about the state paying for you to stay in your own home, to be by yourself, so that you can have care workers coming into the house so they can age in place and live there forever and ever. So neither models, I'm not sure. I don't sit comfortably with either model. I don't want either. I don't want to be in a high-class nursing home, neither do I want to have high-class home care. I want to be connected. I want to be with people. I want to be able to hear laughter. I want to be able to have my beer, even though I'm 90 and got a bit of dysphagia, you know. So I don't know, you know, I think, maybe not even a retirement village. I just want to be able to live where I am, you know, and for all my life.
I agree with Sweet Fund that no retirement age, no retirement homes. Right? I look at this at various stages of my life. One time I was quite excited about the concept, until one day it dawned on me that even in countries where you have retirement villages, how many percent of people live in retirement homes? Very small. So then I said, I'm in public service, I was a minister at the time. Why do I focus so much attention to a lifestyle which some people can afford and want to have, and neglect the needs of the other people who can't afford these retirement villages? Right? And so, changed my thinking entirely. I think there's a place for retirement villages of a certain type, but if it is for the wealthy who choose that as a lifestyle, fine, let the private sector take care of it. But there is a group of people in our society who may need some kind of housing modality which suits them. My thoughts on this are not fully formed. Lynn Boone wants me to develop this. Lynn Boone is the DS, and in charge of the aging office. She wants me to develop this because I think that we do have people who live alone. And if what Sweet Fund is doing in the north succeeds, then we probably don't need it, because you have neighbors who support people who live alone. But we may need a modality for people who living alone who feel more comfortable if they are centralized. If they are centralized, and that we can provide a type of housing which suits them, where they live together with other singles. There are many hurdles to clear, and I think that if you want to have this model where it allows singles to live, it must be in the HDB heartlands. And then we run straight into what are the HDB rules and how we do get this kind of housing model work and so on. So I think there is some for a small group of people. But for the majority of us, Singapore, in due course with the aging process, we are one retirement village.
Do you think the financing structure in Singapore encourages aging in place? So I think Mr. Lim.
Before Ms. Lim answers, and I don't know whether this will help you think through. We did a project in Peacehaven. We took a whole bunch of category 3 patients with dementia who were very disruptive in their own homes, and none of them could be discharged. You know, you rehabilitate them, you send them out to the community, you find that everything breaks down. But then if you cohort them, and these are people with moderate dementia who are still ADL fairly independent in a supervised environment. But if you put them out in the community without any supervision, they forget to bathe, they forget to turn off the gas, they forget to take medicines, and the care needs become very severe. So a lot of these people needed moderate care needs. So the nursing home Peacehaven turned one of the wards into an assisted living facility. So instead of having the regular nurses, they they pulled in people who were able to just accompany the patients. And you found that in an environment where people were able to make choices, serve their own meals, go downstairs to have meals, be it in a cafe where they were able to partner each other, they were the more able ones were able to serve the less able ones. Suddenly the care needs dropped. And to the extent that ministry came and looked at it and said, how come all these people are in this environment? You know, why they all look like Cat 2 and better they can be sent home, but no, you can't. In fact, it's because they have enough support that they are able to be independent. And this is where it comes, you know, actually this facility doesn't need to be in a nursing home. It can be out in a HDB area, but it needs this level of support, without which it's not going to work. So how do you finance for something like that?
Now I know one person to pull into this task force to develop this concept. Chris. Well, the question was about whether our financing engages or supports the aging in place. There are a lot of things still to be done. I was one time in charge of aging issues. I couldn't cover all the various areas that need to be looked at. And when I retired, and then the Prime Minister appointed Gan Kim Yong as the Minister in charge of aging issues, I told him there's, for me, one piece of work not done. And that is intermediate and long-term care financing. We have MediShield, we have ElderShield. ElderShield is a very basic, rudimentary insurance system which few Singaporeans then, and possibly today, find really useful or helpful. And that we need to re-look at ElderShield. And when we have got that sorted out, then I think the support, financial support for aging in place would be a lot better. I don't think it will solve all problems, but it will be a lot better. Mr. Gan decided to focus on the MediShield, so now we've got MediShield Life. That is in itself a big piece of work to be done. He's done that, so it's implemented. Now he will be looking at ElderShield. When he's going to come out, I don't know. You got to ask him, but I know that that has been looked at, and at some point it will come out, and so the financing system will improve. Right? But having said that, we also, perhaps part of this public education, got to remind Singaporeans that we shouldn't be always looking at government for solutions. We should also be looking after ourselves, right? So what does it mean? And this public education is going to be tough, but I think we should do it constantly and get even the young people to think about life when they are 60, 70, 80, 90, 100 plus. And what they will possibly need and what they possibly should do to save and not just depend on CPF, MediShield, and ElderShield. We have to do our part.
Maybe I just like to reframe that and say that our subsidy structure does not encourage aging in place. It's not the financing structure. If you look at the cost of simple things, it only cost me $1.50 to give a person a bowl of soup, high protein, high calcium meal. It's not a lot of money. But if the minute you enter a residential facility, it costs you a minimum of $6 to produce one meal. That is what structure gives. And if all of us want that subsidy, then the co-pay, everything added together, is going to be a lot more expensive than if we come up with creative solutions ourselves.
Okay, I guess we are now running out of time, so we are now at the end of the conference. Please join me to thank the three speakers again. I would like to invite the president of GS up here to give a talk. You see,
I'm not taking over the Professor Goligan's overall summary of this conference. It is too much for me. At the start of the conference, our guest of honor, Dr. Emiko, congratulated our society for its 30th anniversary. And I was just reminiscing, of course, the speakers, Dr. Wong Swee Fan, Dr. Priscilla, and our old friends, and so is Mr. Lim. As I was reminiscing, I remember that the society in 2006 invited him as one of our panel speakers on the subject of financial security for the elderly. Mr. Lim, would you remember that? Okay, it's still intact, huh? The electrician, please note. And then 2011, he was our APCA, Asia Pacific Conference on Aging Guest of Honor. And today, he spoke. It is like a 10-year friendship. So Mr. Lim is a friend of GS. A big hand to him. Now, it's my pleasure to call upon Professor Goligan to do the summary of all the 4 symposiums. Big hand to him.
Okay, got to test whether my brain cells are still working. But before I go that way, I think there's one more thing that we need to do, which is to sort of announce the winners of the 3 posters. So maybe if I could get Professor Chow and Dr. Who else were the other? There's Mary Low to come up to present who are the people who won, and I will tell you which page is the abstract. Okay, so you can come out. You announce the winner, the first author. I will tell our participants where are the pages. Okay. The third prize goes to the paper, page 24. Page 24 by, so.
The title of the poster is actually Designing Depok as an Age-Friendly City in Indonesia. So our friends from Indonesia, congratulations, third prize. The team comprises Vita Priyanti Dewi, Radhan Irawati Ismail, Agnes Purbasari, and Damona K. Pospawardia. I hope I have not got your names wrongly pronounced.
Yeah.
Congratulations.
Thank you.
May we invite you on stage to receive the prize?
Prize? Wait, where's the prize? Okay. Yeah. Okay, so could I have the members of the team to come? Yeah, I think we get the whole team, shall we? Oh. Yeah, thank you. That's very good. Take your time. Very good, very good. Maybe you give you sort of say 2 or 3 sentences about your poster.
Thank you. My name is Vita from Center for Aging Study, Universitas Indonesia. So the poster is about designing age-friendly city for older people.
Yes, yes.
And this is our gang.
Okay, you want to introduce
This is Prof. Ira, this is Mrs. Agnes, and this is the 3rd time we came to this event every year. Yeah, the first time we got the first winner of the poster presentation. Right. The second time, the 3rd winner, and now it's the 3rd winner again. Thank you. Thank you.
will give the prize to you, and we'll take a shot together, huh? Okay, right. Thank you very much. Okay, thank you. Yes. Okay, so.
Right, the second prize goes to the team from the Mediterranean diet and mild cognitive impairment among community dwelling Singapore elderly. So the members are Sun Ye, Zhang Jiachen, Lim Sulin, Li Jialiang, Pan An, Professor Rathi Mahindran, Professor Kwa Yi Hyok, and Feng Lei. Can we have a representative on stage? The abstract is found on page 30. Okay, Professor Goh would like to request the whole team to come on stage, if possible.
Okay, so you're representing the team. Yes. Okay, could you tell our participants something about your poster, the Mediterranean diet?
Sure, yeah. So we were looking at a Mediterranean type of dietary pattern and their association with mild cognitive impairment. So we do find that people who follow a Mediterranean type of diet have a lower risk for cognitive impairment. Yeah, but we recognize that the prevalence of this kind of diet in Singapore population is not so high. So our next step is to identify our own version of a healthier dietary pattern. Yeah.
That's very good. Probably it's a wine. Huh? It's a red wine inside it, I think.
Yes, moderate alcohol drinking.
Yes, yes. Very good. Okay, so congratulations.
Yeah, thank you.
Yes, then we'll take a shot. Okay, thank you.
Thank you, Prof.
Okay, thank you. Okay, right, so we on to the winner of the posters. Yes.
Okay, for this year, the first prize goes to the poster on mindful awareness practice to improve cognition of Singaporean elderly with mild cognitive impairment, a randomized controlled trial. Members include Ng Keng Siang, Professor Rathi Mahindran, Wee Sin To, Professor Goh Li Gan himself, Nor Fazila,
No conflict of
Crystal
interest.
Tan, Chan Hui Yu, Erwin Kiman Chia, Chow Wei Ling, Feng Lei, Ho Roger Chunman, Anis Labi, and also Professor Kwa Yi Hyok.
Yes, and this is your which page?
Page 32,
Page 32,
of
32.
the poster abstract.
Okay, I wonder, besides King Siang, who else are here? Is King Siang here as well? Yes. Right, so the rest of the gang? Okay, shall we ask them to come up as well? Yeah. And then maybe get you to say a few words.
So this is our first RCT in the Jurong Aging Study that began in 2012, as mentioned by Prof. Rathi. So it is a pilot study on mindfulness in Singapore, and the sample size is quite moderate. So we hope that this pilot study will actually give some evidence to bigger study in the future. Thanks.
Okay. Shake your hand first and take a shot. Yeah. Congratulations. Yes, we congrats. And also Fazila. Okay, sure. Let me give to you as the first author. Okay, we'll take a shot together. Okay. Yeah, is it too far away? Maybe you should come to the front. Yeah. Okay. Yeah. Okay, thank you. Thank you. Yeah. Okay. Right, so that sort of concludes the presentation. And once again, let me thank Professor Chow Wei Ling and also Ms. Mary for the being the judges. Okay, so that brings us to the final segment, which is to say something about this wonderful conference. I must say it's going to be a tough call to summarize the whole proceedings to some degree of clarity. So I'm going to say what I could remember, Mr. Boone. Okay, of course, we started off with the idea of the dementia prevention program as the a community-based program, which I think we're probably on the right track. So what you need to remember is that, number one, the intensive lifestyle change, if your lifestyle is not all right, is important. And number two, of course, if you have the 4 high-risk diseases, then better do something about that. The third thing, of course, is that if you have the energy, which I think you should have, come and join one of the community centers to participate in the dementia prevention program. I think that is probably a good investment, I think. And certainly, Mr. Gopal has spoken about this. So I certainly look forward for you to come and join this program. Okay, so that would be the sort of dementia prevention program. Of course, we also had Dr. Roger Ho to talk about the garden therapy. I think that is certainly something that is therapeutic and useful. You can certainly turn your balcony into a sort of a garden. That's not difficult, I think. Again, there are many courses being run, so please come along and do that. And the third paper in the first symposium is interesting because we now can actually look at the brain in terms of the stations, the nodes, and the tracks, very much like a railway system. And with that, we can learn more and more about what actually makes the brain tick. So I thought Dr. Pham's paper is very useful. Okay, so that is the first symposium. Now the second symposium is interesting because it actually looked at the idea of inclusive environment. And the content is quite a lot. So what I would say is that go and look at the abstract and also download the full text, the PowerPoints. I think that will certainly give you quite a lot of ideas. Suffice to say, there are a few points to make. So the idea of the transformation of the environment for successful aging, I think is a concept that we need to take on board, that there are many things we can do to transform the environment. Of course, our environment is a high-stress environment, so we probably need to bring back some of the ideas of make it a bit less high-stress, a bit more natural. I thought that is an important point that I learned from the first speaker. The second paper talked about creative aging cities for all ages, and that one is, again, interesting because creativity actually comes from everybody. So it's an inclusive kind of idea, and certainly more than what the government can do. I mean, the government can take care of all the important things, but the more wonderful things, I think the people should take care of it themselves. That's my viewpoint. So again, many ideas there, right? And the third one is important. I thought the paradigm shift of intergenerational activities is all being focused on competition and conflicts, concentrating on what the two generations can do, the young and the old, in terms of solidarity, unity. I think that's an important idea to take on board. The picture of the small kid on the table trying to share the food with the two grandparents, I think that probably is a good icon to remember. Right? Okay, so there is Symposium 2, environment, very important, new kid on the block. Then the third symposium is on community management of dementia. Whether we like it or not, there will be dementia in our community. But I thought those 3 papers gave me some hope that we can do lots. We can do lots to these people. And the paper by Dr. Soy talks about getting the GP to form the template. So it's actually more from the GP perspective. What does he see to be real? I thought that was a good idea, and we should encourage our GPs to think like that, and just don't depend on specialists. They got ideas of what to do, right? And that's the next paper by Dr. Iris Rotter was good to talk about the community-based care. So going back to patients who are at home, who have difficulty in coming, bringing the services to them, I think that is also something to think about and something to promote as well. And the third paper by Dr. Emily Ho on caregiver support. I think the caregiver is somebody that's often forgotten, that the person is actually suffering too. So we therefore need to give that person equal attention, and indeed by getting a caregiver to be safe and sound will mean that the patient will be benefited. Certainly, I see lots of problems with caregivers who are not supported. So we must not forget this wonderful group of people who is trying to do what they can do, struggling against a demanded person who is disruptive, aggressive and whatnot. So we really must help these caregivers along. And the last symposium is so wonderful. I don't know how to summarize it. Suffice to say, I think I made the right decision. I said that, hey, let's put the best speakers at the end. And just like the American shows, I'm told that they put the best show at the end. So I'm on the right track. Okay, so having said that, let me try now. Okay, what I like about Mr. Lynn Boone's presentation is his statement, life is for living. I think that is a truism that will always be true, right? Life is for living. So the fact that children prevent their elderly folks from doing what they want to do is wrong, right? I said that last year. Let the old lady, the old man do what he wants to do. Why stop him? You know, that is his life. You know? So I certainly support your idea 100%. And if mom wants to cook, let her cook. You know? So long as she doesn't make the house go on fire, that's okay. Let her cook. Agree? So must ask your mom to continue to cook. And this idea of now I can't even read my handwriting. A club-like feel. So that is important, right? The agent organization must give the person a club-like feel. I'm going to a club rather than going to a nursing home. So that is a paradigm shift that all of us who have a hand in planning nursing homes and such institutions must not forget. Make it a club. Make it really a place that's worth going to. And familiarity, just like home, is another idea that I thought is very important. So let's remember to take all those things that Mr. Lim has shared with us. I thought they were wonderful ideas. Let's give him a big hand, shall we? Right. Then we go to Dr. Christopher Lien, who is a philosophical man. I always like to listen to him. He has got lots of interesting things to say. And he made three points that we need to move beyond acute care. I think that's very important. Beyond the acuteness, what happened to the patient, we often forget. So we therefore need to think of a long haul. I think that is certainly an important truism. And that the present healthcare delivery system for people requiring rehab is actually not quite there. It's fragmented. There's skills gap, asymmetry between caregiver and recipient and caregiver. I think we need to try to put that right in the next couple of years, maybe. And then this idea of getting people to be mobile. I think the lady that is skating compared to the man with contractures tells a story. I think every old person must be skating. At least if cannot skate fully, can do a bit of activity near to skating. Minimum stand up and walk. You think so, Chris? I think that is the key idea. And then we move on to Dr. Wong Swee Fan. Swee Fan is always interesting to listen to, right? This idea of distracting the distracted with the sort of what I call it, tapping of the table to create some kind of rhythm. I think that's wonderful. That is the best way to get the sort of distracted person to be calm. No? And then this idea of the beer story. I think the beer story of sort of working in cahoots with the provision shop man to return the beer and the dollars, cycle it every day. is also interesting. But more interesting is that obviously the community program was working. That's why the old man was not there, right? So must really congratulate Sui Fan and her gang for that One North project that they are doing, right? Of course, the next story, the man with the gangrene of the leg, it's actually sad but true. Often the world does not fall apart until the spouse dies. I mean, I see that all the time. So we therefore need to be prepared after the spouse is gone, how to get the man on board. And certainly what was done with the electric wheelchair or the sort of thing, those are the things that we really need to look into. And therefore we must not forget that there has got to be attention for a patient that will fall to the crack simply because the spouse dies. When the spouse dies, often the old man falls to the crack. So let's do something about that, right? Then the couple for all ages, well, this one is really wonderful. Trying to get people to participate, the high protein meal with the soup. I think that is a good example. And what else? Then, of course, getting the schools, the nursing homes, the senior healthcare centers to come forward and develop this integrated program for the elderly so that they have a better future, they live better. I think that's essentially what we're trying to do, or what Sui Fan and her gang in the North has proven. And I think we should take that forward and make it uniform for the whole country. Well, that is my attempt to try and summarize things. Hope my gray cells are still functioning. And let me thank everybody for your sort of participation and staying right to the end. I think it's really wonderful. I'm told that we're supposed to take some picture. Are we going to do that? I don't know whether can we? Okay. So we. Okay, so MC says that we will let you go back. Thank you. We'll see you again sometime down the road. Thank you very much. Yeah.